My name is Ron Blankstein. It's my pleasure to welcome everyone to today's webinar on the new CAD RADs document. We had an extensive group of authors who led this, and I want to thank all of them on behalf of Recorder Corey and myself, who both served as the co-chair. And today's webinar is really meant to share with you what's new in the CAD RADs and how to implement this in reporting, as this isn't something that many institutions, including my own, will now start to use in every cardiac CT report. So without further delay, I'm going to turn over to Dr. Recorder Corey, who really needs very little introduction. He's really the mastermind behind CAD RADs. He led the first CAD RADs effort, and he now led this effort. So really, we are all very grateful for his contributions. And Dr. Curry will share with us what is new in CAD RADs 2.0.
Thank you very much, Ron. It's a pleasure to be here and be, sharing the thought process behind the updated version of CAD RADs 2.0. We have a terrific panel and faculty, and we'll get right in. We have a lot of information to share. So with that, valuing cardiac imaging. So it really started actually back in 2015 when we realized that it's more, the value of cardiac imaging is more than generating a report, right? It's very important to have a patient activation, patient safety, delivery of results, building clinical pathways, doing the right test for the right patient at the right time. Then the second component is the clinical accuracy, which is the quality of images, the accuracy of the reads, and a comprehension of the report by the referring physician. And then coordination of care. So how the results of any imaging study will impact coordination of care downstream, testing, cost, and outcomes. And really, with PROMISE trial, and that we realized that it's not only reporting the coronary CTA, we need to have this communication, have this dialogue, and guide the next steps in patient care in order for CTA to achieve the maximum capacity. So with that, back in 2016, we had the first version of CAD RADs with a goal for a standardization coronary CTA reports to improve communication to referring physicians. It was a collaboration of the Society of Cardiovascular CT, ACR, ACC, and NASCI. Could you please mute your I think there is, yeah, everybody's muted. Very good. We need everybody muted, please. And with that, the classification should be applied on a per patient basis for the highest grade stenosis. And specific recommendations are provided to guide the patient management in a clear and consistent fashion. So CAD RADs really became the framework to standardize coronary CTA reporting and really providing a tool for education, for research, for peer review, for quality assurance, even for data mapping. It's very easy to go back in the past 5 years and map all the CAD RADs 3 and see, what happened with CAD RADs 3, if they had like functional imaging, if they had cardiac cath. It's really easy for data mining and even AI tools. So with that, since 2016, there have been 50 publications further validating CAD RADs, validating the diagnostic accuracy, the prognosis, the clinical impact, the impact in medications and outcomes. We had CAD RADs validated in all major trials like CONFIRM, SCOT-HART, and PROMISE, and really becoming used. We had surveys demonstrating that, before the CAD RADs 2.0, more than 50% of sites worldwide had implemented CAD RADs. And if you haven't implemented, you should definitely consider implementing CAD RADs. So with that, what is new? So in the first version, the main focus was stenosis. And we had the stenosis grading from 0 to 5. and the most severe stenosis would be counted, would go minimal, mild, moderate, severe, and broken down in 4A and 4B for single vessel and two vessel disease for 4A, and left main disease in 4B. So that classification for stenosis remains the same. There's no change. So stenosis remains the same. We'll review that. We added plaque burden there, and there is a specific talk by Dr. Blankstein that will be expanding the plaque burden from P1 to P4 and the reasons that we added plaque burden. And regarding the modifiers, we had 4 modifiers in the past. We had N for non-diagnostic, S for stent, G for graft, and V for vulnerability. We added 2 new modifiers. So the new modifiers that were added is Modifier I for ischemia, and we have a dedicated talk about that for CT-FFR and CTP, and E for exceptions. And the other modifier that was changed was the HRP, which is high-risk plaque, which replaces the vulnerability. We'll talk more about the modifiers. So very important, we always get this question, and once people start implementing practice, well, a proximal LAD lesion, it's also similar to an OM, both will be Cad Rads 4A. That is correct. Both will be Cad Rads 4A because there is a single vessel with severe stenosis if the vessel is greater than 1.5 millimeters. That is why you have the impression of the report, and that's why the Cad Rads should always be used in addition to the impression. The impression of the report, that's where you give all the details and the nuances of the case and the summarization of the case. And the Cad Rads is more like a codification to guide next steps in patient care. So very important that the impression of the report and the Cad Rads classification, they go hand in hand. Also, we have from 0 to 5, where the degree of stenosis remains the same, minimal, mild, moderate, and severe. And then we have P1 to P4 of increasing severity of plaque burden, mild, moderate, severe, and extensive. With that, this table will also be covered in a follow-up talk, but it suffices to say that if you have minimal or mild disease, Cad Rads 1 or 2, there are recommendations for risk factor modification and preventive pharmacotherapy. And the language is consider if you are P1 risk factor modification more affirmative if you are P2, and if you are P3 and P4, if you have severe or extensive plaque burden, you go to aggressive. Also, Cad Rads 3 favoring functional assessment, and a functional assessment could be with nuclear perfusion imaging, CT-FFR, stress echo, stress MR, stress PET, any functional assessment, a stress test. And Cad Rads 4, depending if it's, either will go to ICA or functional assessment, and really depending on the patient's symptom, severity, location of the lesion, a lot of other factors. 4B, which is left main or triple vessel disease, in general, those patients will go to the cath lab directly. Cad Rads 5, which is total occlusion, ICA, and functional imaging, and Cad Rads N for non-diagnostic. If you have if you don't have a segment that is moderate or severe stenosis, Cad Rads 3 or more, and you know that the next step will be a functional testing or further invasive angio, then the N is a modifier. Otherwise, if you have minimal or mild disease, you're not able to exclude a disease, Cad Rads N will be a classification. So with that, you also have a breakdown for acute chest pain and a stable CAD, so that will be covered. And for Cad Rads 2.0, it's first stenosis, then plaque, and then the modifiers. So you have your stenosis from 0 to 5, then you have plaque from P1 to P4, and then you add modifiers if present. I would like to highlight just 3 modifiers. I, which is for ischemia, that you can have I plus, I minus, I plus if you have ischemia, I minus if there's no ischemia, and I plus minus if it's a borderline case. This will be further elaborate. And the modifier E for exceptions. This is a new modifier and refers for the cases that you have a compression or a stenosis, but it's not due to atherosclerosis. It might due to a coronary dissection, anomalous coronary artery, coronary aneurysm, vasculitis, fistula, and other causes. But that's the modifier E for exceptions. And you should add, CAD RADs 3 or 4, or 1 or 2 or 0, if there is a stenosis or not. And you add the plaque burden, P1 to P4, and then after that, you add your modifier, in this case, modifier E. This is one example just to illustrate a patient with anomalous coronary artery, RCA arising from the left sinus of Valsalva, moderate compression proximally. So this will be a CAD RADs 3. There is no plaque burden. If there is 0 plaque burden, you don't need to add the P, very important. And then the modifier E for exceptions, because this is an anomalous coronary artery. Also, one example for modifier I, which is a new modifier, a patient that had severe stenosis in the LAD. We can see this densely calcified plaque with non-calcified plaque. So this would be a 4A because there is severe stenosis, a P4 because there is extensive plaque burden. And then this patient had CTP, and we can see here ischemia and reversible ischemia in the LAD distribution. So the modifier will be I plus. So stenosis, plaque, and modifier with that framework. And this is one other illustration just to show a case of HRP, severe stenosis in the proximal RCA will be 4A. In this case, there was just that main plaque, but the P1, because there was just mild plaque burden, we counted the total plaque burden in the coronary, and you had HRP, you had the napkin ring sign, you had positive remodeling and low Hounsfield unit, so a high-risk plaque. So again, stenosis plaque modifier, 4A for severe stenosis, P1 for mild plaque burden despite local and severe, and the modifier for HRP. So with that, CAD RADs, it's here to stay. You definitely should embrace it, and there's a large amount of evidence supporting CCTA and CAD RADs to be utilized in practice. It links clinical pathways with accurate reads and specific recommendations to impact outcome, very important. It led to a standardization of report for CCTA. And in the end of the day, precision medicine starts and begins with precision in diagnosis, and CAD RADs is one more tool to be used in that regard. So with that, I will pass to Dr. Williams, and actually Dr. Blankstein, and we'll have Q&A in the end of the meeting.
Great. Well, thank you, Ricardo. Really a terrific presentation. I'm going to talk about plaque burden and management recommendations. I know Ricardo gave a really nice overview, and I would share with you that I think plaque burden is probably the single biggest change in this document when you look at the prior version. And in fact, plaque burden is now something we should report on every single coronary CTA, unless it's normal. If it's a CAD RADs 0, you don't need to talk about plaque burden. But if there's any plaque, you now have to give a P designation, and that's going to be P1, P2, P3, and P4 for mild, moderate, severe, and extensive amount of plaque. We had a lot of deliberations on how can we provide this information, and ultimately we wanted to allow flexibility for sites. So we offer 3 different ways to estimate how much plaque is present. One of them is a calcium score, and we recognize not every institution does a calcium score with every coronary CTA. My own institution, for example, does not, and there's pros and cons of adding a calcium score to coronary CTA. So if you do a calcium score, you can see on this slide how that can help you estimate the amount of plaque. The other option is to use a segment involvement score, and that means counting the number of segments that have plaque, and that gives you a fairly good estimate of how much plaque is present. And you can see here, if it's 8 or more segments with plaque, we would say that's extensive plaque. If it's less than 2, that's mild, and moderate and severe in the middle. The third approach is a visual evaluation, and that is looking at how much plaque is in every vessel. So if you have 1 to 2 vessels with a small amount of plaque, that's mild. That's probably the corollary of a calcium score under 100. If you now have 3 vessels and each one has a little bit of plaque, that's moderate. If you have 3 vessels and at least one of them is going to have a large amount of plaque, that would be a severe amount of plaque. And if you have 2 to 3 vessels that have a severe amount of plaque, then overall that's going to be a P4, because the overall amount of plaque for that patient will be severe. Now, a common question that might come up is, well, there are 3 approaches here. What if there's differences? What if your visual inspection says one thing based on this, and the calcium score puts you at a severe or not extensive? And what we recommend is using whatever is the highest. So if you happen to do a calcium score and look at a segment involvement score and do a visual evaluation, whichever one provides you with the highest P level, that's the one we recommend using. We acknowledge that there's some variability in how people are going to apply this. And ultimately, what one institution or one reader might call a P3, another person might call a P4. And that's okay. We want everybody to get used to reporting the amount of plaque. We think that there's going to be pretty good consistency, but if one person thinks that something is P4 instead of P3, that's not going to lead to a huge difference in management. But the fact that as a society, as a field, we are now going to start reporting how much plaque there is will be very important. So let's talk about the patient management recommendations. And I want to start by first of all sharing with all of you that this is an expert consensus document. This is not a guideline. And as such, it is informed by guidelines. And I listed on this slide some of the key guidelines that we used. But it also is informed by recent clinical trials. Some of these trials, were not in the guideline, but this is an expert consensus. And as such, you have to remember that not every case is always going to be defined by this group. And in fact, the management that we provide in this document, at the end of the day, it's just a suggestion, and it is not meant to replace clinical judgment. And I think that's an important point to note. So I now want to share with you table 4 and 5. These are the tables, table 4 for stable chest pain, table 5 for acute chest pain. These are of course very busy tables, and I recognize you're not going to be able to read them on this slide. You can go back and look at them later. But what this shows is for every CAD RADs classification, what would be the cardiac investigation that's required. And by cardiac investigation here, we are referring to tests to evaluate for ischemia, like a functional test, or invasive angiography. So that column on further cardiac investigation will show us, what other tests are needed, as opposed to the column all the way on the right. That's the management consideration. And that's what recommendations we may provide clinicians for management. And those will differ depending on the amount of plaque. Again, that's a big change from the last CAD RADs. So similar for table 5 for acute chest pain, we also have cardiac investigation, and then we have management considerations. But instead of table 4 and 5, I actually wanted to share with you tables 10 and 11, which really take the exact same information, but they try to distill it down to specific bullet points for the key recommendations we would give in every scenario. And the reason why we created these tables is that all of us as imagers can copy and paste the recommendations from tables 10 and 11 right into the report. It's actually hard to do from tables 4 and 5 because it gives a lot of permutations based on the amount of plaque. But if you look at 10 and 11, it really has all the permutations of CAD RADs and the stenosis score and the P score. And then you can see what are the actionable recommendations to put in the report. So if you wanted to cut and paste recommendations into your report, this is a good table to look at. The other thing I wanted to do is give a plug here to AvoMD, which is a vendor that in collaboration with SCCT actually created an app, and this can be downloaded to your phone, or this could be used online on the same computer you use to read cardiac CT, and that will also give you these recommendations in a manner that you can cut and paste them into your report. Of course, ultimately, you may want to include this within your EHR system or within the system you use to report cardiac CT, so you don't have to copy and paste, but at least until you get your system updated, this is one thing to do. So let's dive a little bit deeper into these recommendations. I'm first going to talk about the recommendations for stable chest pain and then into acute chest pain. So for stable chest pain patients, what we can see here for Cad Rad 0, reassurance, nothing different from prior. If you now have Cad Rads 1 or 2, the recommendations are actually the same, whether you have minimal or mild stenosis. And really for Cad Rads 1 and 2, the recommendations are going to change based on the amount of plaque rather than the stenosis. If you have either Cad Rads 1 or 2, this is all non-obstructive disease. If you're P1, we're going to say that's a small amount of plaque, consider risk factor modification. If you're at P2, we're now saying risk factor modification and preventive pharmacotherapy. That's a formal recommendation now. And if you're P3 or P4, and that's the equivalent of a calcium score that would put you in severe or extensive amount of calcifications, we now are recommending aggressive risk factor modification, because the amount of plaque in this case would put you at the same level of risk as patients that we often think of as secondary prevention. So again, this is all for patients with non-obstructive plaque. Now in table 10, if I now focus on Cad Rad 3 and above, this is now patients that have obstructive disease. For Cad Rad 3, similar to the prior Cad Rads, we are recommending functional testing, so nothing that's different there. And I think this is important. We're not recommending cathing moderate stenosis. But if you do an investigation for ischemia like FFR CT or like CT perfusion, if you now have an I+, then we may consider invasive angiography, especially if there's frequent symptoms that persist after medical therapy. So you always have an option to try medical therapy. You never have to go to the cath lab just because of a CT results. But if there are frequent symptoms, if there's evidence of ischemia, certainly that would make a compelling case to have invasive angiography. For Cad Rads 4, we continue to recommend, similar to the prior version, to either do invasive angiography or functional testing. And there's some footnotes in the table for consideration for factors that may favor invasive angiography or functional testing. You can read those in the document. For Cad Rads 5, we also offer the possibility of doing viability assessment. Cad Rads 5, of course, is an occluded vessel. And for all of these categories, 3, 4, and 5, once you have obstructive disease, when it comes to preventive therapies, we are recommending aggressive risk factor modification and preventive therapies. So that's in common for every category here. So this distinction based on the amount of plaque essentially is more important when you have non-obstructive disease. Once you have obstructive disease, we are recommending aggressive prevention. So everything I just talked about was for stable chest pain. Now let's look at acute chest pain. If you have a Cad Rad 0, again, this is reassuring. If you have a Cad Rads 1, if it's P1 or P2, refer for outpatient follow-up. If you have a Cad Rads 1 was a P3 or P4, again, more plaque, we now also are recommending referral for outpatient evaluation. But at this point, we added the word aggressive risk factor modification because these are patients who have a large amount of plaque. What about Cad Rads 2? Cad Rads 2, if there's suspicion for ACS that's high, if the troponin is positive, if there's high-risk plaque features, at this point, we are going to consider hospital admission in cardiology consultation. Again, you don't have to. You can send some of these patients home. But Cad Rads 2, if there's mild stenosis and there's other high-risk features as listed on the slide, this is where we are going to recommend admission. Again, this is for acute chest pain. If there's P3 or P4, the difference here is that we're recommending even more aggressive risk factor modification. And of course, often this is beyond the hospital, the acute hospitalization. And then here for my last slide, this is again acute chest pain, but now for patients who have obstructive disease. If you have Cad Rad 3, similar to stable chest pain, we're recommending functional testing. If you have an I+ because you did an evaluation for ischemia, this is where invasive angiography should be considered. If you had Cad Rads 4A or 4B, we're really recommending for 4A invasive angiography or functional testing. In 4B, similar to stable chest pain, 4B is going to be 3-vessel disease or left main disease. At this point, we think you should go straight for invasive angiography when you have that particular finding. CAD RADs 5, when you have an obstructed lesion, if there's suspicion that this is an acute obstruction, this is where we would now recommend expedited invasive angiography. So again, all of this is summarized in the tables. I especially like 10 and 11 because it's a more concise overview, but if you want to dive into the details, you can also look at tables 4 and 5 to really dive into the nitty gritty. So with that, I am going to turn it over to our next speaker, and that is Dr. Michelle Williams, who's a radiologist at the University of Edinburgh. She's also one of the co-authors of the CAD RADs and co-author of many other important documents related to this. So turning it over to you, Dr. Williams.
Thanks very much indeed, Ron. My internet's not great today, so Ron's very kindly going to run the slides for me. So next slide, please, Ron. So I'm going to talk, here are my disclosures, and next slide, please. So I'm going to talk about the new I modifier. I'm going to talk a bit about why we introduced this into the CAD RADs documentation this time around, how to use this modifier, and a couple of example cases. So next slide, please. So the reason that we have this I modifier is that we all know that CT coronary angiography for coronary artery disease is about so much more than just stenosis and plaque. Stenosis and plaque are the most important thing in the CAD RADs documentation, I think, but we wanted a way to incorporate these other things as well. Next slide, please. So first of all, let's talk about CT perfusion. So some of you will use CT perfusion, some of you will not. And the idea of this is that after you've done your rest CT coronary angiogram, you give a bolus of pharmacological stress agent or infusion, often adenosine, maybe regadenoson, and perform a second acquisition during stress. So this is very similar to the way you do SPECT or MRI perfusion imaging, looking at the identification of perfusion defects and in particular reversible ischemia between the rest and the stress images. Next slide, please. So the other thing that's incorporated into this I modifier is CT-FFR. So there's a variety of different ways to do this with computational fluid dynamics or machine learning techniques, and we wanted to incorporate this information into the CAD RADs terms. There's a couple of definitions that are quite important in the CAD RADs documentation. We're often talking about lesion-specific CT-FFR, and this is the CT-FFR 1 to 2 centimeters distal to an area of a coronary stenosis. And that's the one that should be considered to guide decisions around revascularization and invasive coronary angiography. Another term that may be familiar to some but not everyone is translational pressure loss, also called delta CT-FFR. And this is the pressure loss from 1 to 2 centimeters proximal to 1 to 2 centimeters distal to a stenosis. And a delta FFR greater than 0.12 is considered significant. So the idea of this is all of this information is obtained from a single CT coronary angiogram, the same one that you're doing your diagnostic assessment from, with some extra computational techniques. Next slide, please. So putting that all together into the I modifier, it's introduced in CAD RADs 2, as we've said already, and it indicates that an ischemia test has been performed, and that's either CT-FFR or stress CT perfusion. And the idea of this is to communicate this information alongside all those other CT parameters. So alongside stenosis, alongside plaque, a comment on that these tests have been performed and what they find. Next slide, please. So as well as having the I letter there, we also have some pluses and minuses. So this indicates what the results of these ischemia tests mean. So plus is abnormal, negative is normal, and plus minus is borderline, indeterminate, or inconclusive. And we're going to go on now to chat about what abnormal and normal mean for each of these different tests. Next slide, please. So for CT-FFR, it may be used in coronary stenosis ranging from 50 to 90% to better define if a coronary stenosis is hemodynamically significant. So this is particularly for patients who are CAD RADs 3 and CAD RADs 4A based on stenosis. It could also be considered in patients who are CAD RADs 2 if it's a proximal lesion greater than 40% or if there are presence of high-risk plaque features. Next slide, please. So this is taken from one of the tables in the CAD RADs documentation. I've slightly summarized it a bit because it's a little bbit much to fit on a single slide. So do have a read of the paper to get more of the details. For CT-FFR, abnormal, I+, is a CT-FFR less than 0.75. An I- is a CT-FFR greater than 0.8. And a borderline, I+ or minus, is 0.76 to 0.8. And for each of these, there's different considerations in terms of what the interpretation is and what the suggestions for next steps are. So for a patient who's I+, CAD RADs 3 or 4, the interpretation is that you have an anatomical stenosis in one vessel with lesion-specific abnormal CT-FFR of 0.75. So we offer the suggestion to consider invasive coronary angiography if they're likely to benefit from revascularization. At the other end, the I- patients, so CAD RADs 3 or 4 and I-, there's two possible interpretations of that. One is that we have an anatomical stenosis with a lesion-specific CT-FFR of greater than 0.8. The other is that we have that, but at least one distal vessel has a value of 0.8, but it's not associated with a specific stenosis. So an abnormal CT-FFR less than 0.8, but not associated with a specific stenosis. And in both of those cases, the consideration is to defer invasive coronary angiography and instead optimize medical therapy. In the borderline group, we've got a few other options in our management recommendations. And considering invasive coronary angiography if individuals are likely to benefit from revascularization based on symptoms, lesion location, or translational pressure loss, that delta FFR. So we've got three options there for CT-FFR. Next slide, please. For CT perfusion, it's indicated in a similar range of patients. So the same 50 to 90% stenosis in order to better define their hemodynamic significance. And that's particular CAD RADs 3 and 4, but could also be considered in CAD RADs 2. Next slide, please. And when it comes to CT perfusion, the I modifier really is communicating the results of reversible ischemia. So anyone who does CT perfusion knows that it can do more than that. It can tell us about infarcts, it can tell us about other things as well. But the I modifier is telling us primarily about reversible ischemia, presence or absence. So an abnormal, I positive, is when you have myocardial ischemia in a defined coronary artery territory. So a perfusion defect on stress that disappears on rest. I negative is when you don't have that. So there's two different situations this might be. You might have a myocardial infarct, so a perfusion defect presence on rest and on stress. Or you might have no evidence of ischemia and no evidence of infarct in a defined coronary territory. And then the borderline ones are the ones in between. So in particular, peri-infarct ischemia in a defined coronary territory that's partially reversible. So you can see how this I+ for CT perfusion is telling us primarily about reversible ischemia in these patients. Next slide, please. So here's just a couple of cases to finish off this section. So here's an example of a patient with a severe stenosis, 70 to 90%, a moderate plaque burden, and CT-FFR was performed and the value was less than 0.75. So that's CAD RADs 4A, P2, I+. Next slide, please. This second case, we have a severe stenosis, 70 to 90%, severe plaque burden, and a stress CTP demonstrating reversible ischemia. So this patient is CAD RADs 4A, P3, I+. Next slide, please. So in conclusion, the I modifier is new in this version of CAD RADs. It indicates that a CT-FFR or CTP has been performed. And we have I+, I-, and I+- that indicate abnormal, normal, or borderline indeterminate inconclusive. Thanks very much. You can stop those slides now, Ron. And I'm delighted now to welcome our two next speakers who are going to be showing us a few more cases. So first of all, we had Anam Waid, who's the Chief Cardiovascular Imaging Fellow at Brigham and Women's Hospital. And secondly, we have Randerson Cardozo, who's Cardiology and Cardiac Faculty, again at Brigham and Women's Hospital. And they're both going to show us some interesting cases. Thank you very much indeed.
So I'm going to be presenting coronary CTA cases in patients with stable chest pain. I have no relevant disclosures. And my first case is that of a 74-year-old female with dyspnea on exertion. She had a past medical history of hypertension, hyperlipidemia, prior smoking history. The only imaging we had was a normal echocardiogram. And so she was referred for a coronary CTA. This is a representative curved MPR view of her LAD showing a small amount of calcified plaque in her proximal LAD and some non-calcified plaque in a subsequent segment, resulting in minimal stenosis, as you can see on the cross-sectional view through the area with plaque. This is a representative view of the patient's left circumflex showing a medium amount of non-calcified plaque in the proximal vessel, resulting in what looks like moderate stenosis. And this is confirmed by looking at the two comparative cross-sectional views. This is taken proximal to the stenosis, and this is taken at the level of the most severe stenosis, confirming about 50 to 69% reduction, confirming moderate stenosis. This is a curved MPR view through the RCA showing no plaque or stenosis. The lumen is smooth and there's no obstruction. And so this puts us in the Cad Rads category of Cad Rads 3, as the most severe stenosis that we saw was moderate stenosis of the left circumflex. When it comes to plaque assessment, there are about 3 segments involved, putting us at moderate plaque P2. And so for this, these recommendations are taken from table 2.
All right, Anam, just can you click on your top display? You're showing the presenter mode, so you just need to share another.
I'm so sorry about that.
It's okay.
Is this showing appropriately now, Ron?
Yes, perfect. Thank you.
Sorry about that. So this is taken from table 10 of the Cad Rads recommendations. And for the Cad Rads 3P2 category, it is recommended that we do aggressive risk factor modification, preventive pharmacotherapy, other other therapies like anti-anginal therapies for guideline-directed care, and functional assessment with either a CT-FFR or a stress maybe is recommended. So an FFR was sent in this case, and the FFR values were well above the 0.8 cutoff for hemodynamic significance, indicating that this is ischemia negative. And so overall, the final Cad Rads classification after integrating all the data is Cad Rads 3P2I negative for this case. My next case is that of a 65-year-old gentleman with chest pain. The past medical history that we had was hyperlipidemia. He was having some chest pain with exertion. He hadn't had any prior cardiovascular imaging. And these are representative curved MPR views of his coronary arteries. The LAD curved MPR view shows that there is a medium amount of calcified as well as some non-calcified plaque in the LAD, really resulting in some mild stenosis at that level. In the RCA, we are seeing some non-calcified plaque as well as some calcified plaque resulting in minimal stenosis. And then in the circumflex, we are seeing a small amount of calcified plaque in the proximal circumflex resulting in mild stenosis. And so overall, the categorization for this case becomes Cad Rads 2, mild stenosis. With regards to overall plaque assessment, we have a moderate amount of plaque with about 4 segments with plaque burden in this patient. And then the final Cad Rads classification here is Cad Rads 2, P2. And those are my cases. I will now hand over to Dr. Cardozo after going through the recommendations. Basically, again, non-atherosclerotic causes of symptoms should be considered and risk factor modification. Thank you very much.
Thank you, Anam, for sharing those cases. It's my pleasure to be here today. I'd like to thank the SCCT for the invitation to talk to present this case of cardiac CT in the ER. I have no disclosures related to this case. This case is of a 57-year-old woman who has multiple coronary artery risk factors, but no established coronary artery disease. The patient has a history of hypertension, hyperlipidemia, a BMI of 45, and tobacco smoking. She presented to the ER with chest pain that was quite concerning for an acute coronary syndrome by history, described as substernal, severe in intensity. But her biomarkers checked on presentation and then 3 hours later with high sensitivity troponin were negative. As you can see here, the ECG was normal. There were no evidence of ischemic changes. This is an algorithm from the 2021 chest pain guideline. And as you can see here, it's recommended to use the clinical decision pathway to provide some objective assessment of these patients with suspicion of ACS. On the basis of the negative serial troponins, this patient would have been classified as low risk. And in fact, the guidelines put more emphasis on that specific clinical decision pathway. But because of a moderate heart score, another clinical decision pathway was used and the patient was recommended for a cardiac CT. On coronary CT, what we see initially here in the right coronary artery is multiple areas of a small amount of plaque, but ultimately resulting in multifocal areas here of calcified plaque in the right coronary artery. Here you can see in the proximal, in the mid, and then here in the distal horizontal segment of the right coronary artery. Likewise, the patient also had predominantly calcified plaque in the left main, in the proximal and mid LAD, as well as the circumflex artery. And the highest grade of stenosis was actually in the proximal LAD, where the patient had here both calcified and non-calcified plaque, resulting in mild stenosis. So on the basis of the mild stenosis, the patient was classified here as a Cad Rads 2 with mild non-obstructive disease, unlikely to be responsible for her symptoms. However, the total plaque burden in this case, as shown by the multiple segments involved, the patient was classified as a P3, as a severe overall amount of coronary plaque. And as this was shown by Dr. Blankstein, this can be classified by multiple different ways. In our service, we don't perform a non-contrast CT scan for calcium score along with the CCTA. So in this case, we can use the segment involvement score, which was a 7. All the segments in the RCA were involved, the left main, 2 segments in the LAD, and the circumflex. So the segment involvement score of 7 would put the patient at a P3, severe overall amount of coronary plaque. The recommendation for this patient, according to the Cad Rads 2.0 document, would be that if there is a clinical suspicion for ACS or elevated troponin, consider hospital admission and cardiology consultation. None of these factors were present. So again, it's unlikely that obstructive coronary artery disease were the likely culprit of the patient's symptoms. However, the guidelines also recommend, the document, the Cad Rads 2.0 document recommends, in these cases, referral for outpatient cardiology follow-up and aggressive risk factor modification. And in our patients specifically, there are lifestyle measurements that we would recommend regardless of the CT findings, such as smoking cessation and weight loss. However, there are direct implications on these findings of the coronary CT in terms of medical therapy for this patient, who otherwise does not have a high LDL cholesterol, but with the knowledge of the risk factors and specifically the plaque burden, the patient would have an indication for high-intensity statin, and you might consider aspirin initiation for this patient. Again, I want to thank for the opportunity to present this case, and I'll hand it back to you, Dr. Blankstein.
Great. Well, thank you very much, Randerson and Anam. Terrific cases, really showing how we use this in practice. Lots of great questions in the chat. We've been trying to answer some of them. But I'll kick off with a couple questions to each of our speakers. Let me first turn to Ricardo. I know this is a question about a topic that we've talked a lot about as a committee, is how do you handle the fact that if you have a severe stenosis in the prox LAD, that's a CAD RADs 4, and if you have a severe stenosis in the second OM, which may be a small vessel, that's also CAD RADs 4. Tell us a little bit advice of how to convey that in the report, realizing that those are different scenarios.
Sure, Ron, great question. And, we discuss a lot in a balance of having a classification that is relatively simple to put in place and to convey the information. So that is why it's really important to emphasize that the CAD RADs is always complementary to the impression of the report. And the impression, we provided a template in the main paper that we suggest to have a framework similar to CAD RADs that is like first to describe the stenosis, and if there's no significant stenosis or if there is a severe stenosis or any other vessels, then you can put your impression number 2, plaque burden. And very important to emphasize that if you use calcium score, you should also be adding the non-calcified plaque burden to that section. So you can say, moderate calcified plaque burden, your calcium score might be 200, but you might add that there's mild non-calcified plaque burden. Very important to also add the non-calcified plaque burden, even if it's qualitatively. And then number 3, modifiers, extra cardiac findings, and so forth. But going back to your question, very important that if you always use the impression and the CAD RADs, for what you have a severe stenosis, it could be a severe stenosis in a diagonal, a OM, or a proximal LAD, or a left main. Left main would be 4B, but it could be any other vessel. But with the combination of the impression and the CAD RADs classification, you would cover, and the OM, you might favor a functional imaging strategy, a proximal LAD with a 90% stenosis, and depending on how symptomatic is the patient, you might favor an invasive coronary artery strategy. But you are conveying that part.
Yeah, great. Well, those are really important tips. I know actually Dr. Cardoso was reading a cardiac CT, I think not too long ago for us. And I remember that the impression was severe stenosis of a second diagonal comma, which is a small vessel. So tell us, Ray Anderson, I've seen you put that in reports. What are you trying to convey to the referring clinician when you put that this is a small vessel?
And thanks for the question, Dr. Blankstein. It's just as we were talking just now, it's the relative importance of the territory that's being perfused by that vessel, and that certainly may guide patient management. In terms of preventive therapies, I think the total plaque burden is still the main driver of outcomes. But in terms of relating the symptoms to the ischemic burden, I think it's important to give a sense of the territory that's at risk with that vessel that's involved in the severe stenosis.
Okay. So here's another area that comes up a lot, and that is the aspect of quantitative plaque. We talked about the fact that we now want everyone to comment in every CT report how much plaque there is, P1, P2, P3, P4, and we give various methods to do it. And I think the advantage of the methods that we have provided is that they could be done at the time that you read the CT. They're very simple. They don't take a lot more time. Looking at your calcium score, doing a segment involvement score takes seconds, and the visual evaluation of how much plaque in every vessel, that's also very quick. But we all know that what's around the corner is quantitative plaque analysis, where hopefully we can press a button and get a nice quantitative assessment of the amount of plaque. And Dr. Michelle Williams, of course, is one of the leaders in this area. And I'm going to ask Michelle, why did we not include that quite yet? Why, share with us the discussion we had about including that type of information in CAD RADs 2.0. Why is that going to be in 3.0 and not 2.0?
Yeah, I'm really excited about quantitative plaque assessment, and I really hope that it is in 3.0. It's not quite yet ready for clinical practice, is the bottom line. It doesn't have quite the standardization, doesn't have quite the availability, is just not quite there. It's very, very close, and automated analysis that's quickly available will really make this something that we can use in clinical practice. Most softwares at the moment either have to be sent away or take some time to actually do that analysis. And we wanted to include something in the P modifier that everyone could use right now. So there's an option in that table for a plaque assessment that every single person can use without really much extra training. Looking at the number of vessels involved, if you've got a calcium score, look at that. Segment involved score, the most easy of all the different scoring systems. There are other scoring systems available as well, but segment involved, the easiest one. So we really went for the low benchmark so that every single person could do it starting right now, rather than waiting for the next one. And I'm pretty sure that quantitative plaque assessment and a whole variety of other exciting things in that area will be in CAD RADs 3.
Great. Thank you, Michelle. I'm going to turn it over to Dr. Waheed, who early in our discussion today, she had a great question that I thought would be best directed towards Dr. Curry. So,
yeah, so I was wondering, one of the things that as a trainee I've come across is that if you have a perfectly valuable scan, except for one segment, one small segment, how do we kind of categorize that?
Perfect. Great question. And I think there was a question in the chat as well, and I'll try to elaborate a little better. So it really, if there is one segment, you look at the other segments, and it really depends on what the other segments are telling you. If the other segments are demonstrating, let's say, a CAD RADs 3 or greater, so if there is a moderate or severe stenosis in the other segments, then you are going to take that because you know that you already found a moderate or severe stenosis, and that patient will need further functional imaging or invasive angiography, most likely. So you put CAD RADs 3 or 4A, and then you add the N for non-diagnostic as a modifier. However, if your other vessels had just minimal or mild disease and you still have your non-evaluable segment, you are not able to exclude a severe stenosis. If there is no way to assess that segment, then you would be adding not the modifier N, you would use the N as a classification. So you would have CAD RADs as N as a non-diagnostic study, and then you need to do alternative testing, repeated case, or further imaging.
Thank you.
I'm just going to answer a question from the chat. It was actually about the AvoMD app, which is, you can download to your phone. And one of the questions on there is that it gives an option to filling out stenosis in the P classification. But what about the other modifiers? And the answer is it's actually all in there. If you have a stent, if you have a bypass graft, if you have high risk plaque, that is all in that app as well. So just to answer that question. But on that topic, it kind of reminds me of a tweet I saw over the weekend from the NASCI meeting. Someone had a mnemonic just to remember the order of all the different modifiers. And of course, we like to keep this simple. We don't want you to have a mnemonic. So Michelle, tell us a little bit, some advice on the order of modifiers. Does it matter?
So the simple answer to that is no. There's two things that do matter. First is stenosis. Second is plaque. And after that, put the modifiers in any order you fancy. As long as they're there, it doesn't really matter what order they're in. But yeah, first stenosis, second plaque, and then everything else.
Okay. And just adding, Ron, like just a quick note for the modifiers. It's really intuitive, many of the modifiers. So if there is a stent or a bypass graft, you'll be including, modifier S or G. Just for the presence or a stent or bypass graft, and then it depends on if there is a severe stenosis or not in the either in the stent or in the other vessels. Then HRP, if you have a high risk plaque, you might be using that. In general, we see high risk plaques in like 1-2%, in general less than 5% of cases. It can vary depending on the study. But in clinical practice, you just need to be not overuse. We have seen, trials and that have overuse, vulnerable plaque and high risk plaque, but it's in the single digits. And then you have modifier N, you have modifier E as an exception, and the I only if you are using CT-FFR or CT perfusion. So they are really to be intuitive and to add additional information to the stenosis and plaque framework.
Yeah. Great, great points. I'll add one point on high-risk plaque that actually in the prior version that used to be called vulnerable plaque, and that term has kind of fallen out of favor for various reasons. So we actually changed that to high-risk plaque. So that's a slight change in the terminology. And to have high-risk plaque, you need at least 2 features. So if we think of all the different features for high-risk plaque, just having any one of those alone, like spotty calcifications alone or positive remodeling, is not enough. You need to have 2 of the 4 features in order to be able to say that high-risk plaque is present. I'll open it up to see if there's any other questions. If not, I'll answer another question that was sent my way about the eye. We talked about I+. Michelle shared with us, it's about CT perfusion and CT-FFR. What if there's ischemia by another modality, a stress MRI, a nuclear stress test? And certainly that's important to integrate as well. And if you happen to have that information, and if you're comfortable integrating that, you can certainly in the impression say that there's, for example, severe stenosis in the left circumflex, which corresponds to the area of severe ischemia seen on a nuclear stress test. You can do that, but the I modifier is specifically to indicate that an evaluation of ischemia was done using CT. So just to clarify that particular point. I think we're going to wrap up, and I'm going to ask every speaker to have a 1-sentence or closing thought, either something that they are excited about CAD RADs, or something that maybe we forgot to mention, or something that they want to see in CAD RAD 3.0. So I'm going to turn to every speaker. We're gonna leave the last word to Ricardo here, but anyone can tell us their thought about CAD RADs. I mean, I'll start by the fact that I say that this was a really nice natural progression, that the data in the field has really supported the importance of plaque in terms of prognosis and management. So I personally, as someone who's very interested about prevention, I'm excited about the fact that we are focusing more on plaque and not just on how much stenosis, but that's like one of my takeaway points. I'll turn it over to Dr. Williams.
Thanks, Ron. I'm really excited about the fact that plaque is now right there in the guidelines, as well as stenosis. We know the coronary arteries are about more than just stenosis, and plaque's right up there, and I hope everyone's using it tomorrow.
Great. Anam, I'll turn to you next. What do you think is exciting?
Thank you, Dr. Blankstein. I think what's exciting is that there is a semi-quantitative plaque burden assessed in the report, which is really going to help convince patients to change their lifestyles and be more adherent to statins. I think that's the key.
I'm very excited about CT-FFR, and I'll just make a quick point about it as well, is to integrate the clinical judgment also in requesting CT-FFR. Just as a reminder, it was mostly validated to prevent the outcome was target lesion revascularization, urgent revascularization. So some cases, ischemia may not be a major question of the study, and it's not always indicated as a reflex for moderate stenosis, for example.
That's a great point. And Ricardo, you have the last word, and you'll close out our webinar for today.
Thank you very much, Ron. Always a pleasure to co-chair both the guidelines and this effort. This webinar with you, I think, was a great effort, a lot of great insights, and really excited of building in CAD RADs 1.0 or the first version. And really the field is evolving with all the plaque information and also ischemia. And I think now we are able to incorporate both, P1 to P4 and the ischemia with CT-FFR or CT perfusion, and possibly with future ways of detecting ischemia. So really being able in a very concise manner to be able to add that. And I think this will look, 5 years from now or 10 years from now, and be able to, research database, education, map for AI, look for patient outcomes, really easy mapping or reports, use natural language processing to follow up with outcome. So I think really will have a profound impact in how, we track our reports and we track the impact that our reports are doing. And we try to do that, which is hard, in a simple way or relatively simple way, and try to make it simple. So thanks everyone for participating. We had a great participation, over like close to 200 people in certain point of the webinar. So really thank you so much for participating, and engaging with the Society of Cardiovascular CT and be a driving force for implementation of the new CAD RADs and in your practice.
Excellent. I'll just add my thanks to the speakers, for the audience, for our sponsor for this webinar, which is Clearly, and last but not least, as always, to the SCCT staff, who are always amazing for everything they do, including putting this webinar. Thank you all.
Thank you very much indeed.
Thank you all.
Thank you.